Hi, I'm Dave Fornell, a digital editor with Cardiovascular Business, and I have with me Charles Davidson. He is a professor of medicine at Northwestern University and the vice chair for clinical affairs in the Department of Medicine, and the clinical chief of cardiology and the medical director of the Bluhm Cardiovascular Institute. I wanted to find out from you, what do centers that are interested in building a structural heart program, what should they be looking at, what questions should they be asking?
So I think first thing is there a commitment to the program? Is this something that the hospital and the physicians and administrators really want to take on? Because it is going to require building a team around this program, and there's going to be an investment in time and in finances in order to build a high quality program.
And that starts with building a heart team, starting with the cardiac surgeons and the interventionalists. And it's centers that might not have a close working relationship. What do you do?
Yeah, so I think that's critical. You have to have a cardiologist and cardiac surgeons that are going to work well together, that are really working toward the patient's needs, right? How do you address the patient's needs? Whether it's cardiac surgery, whether it's an interventional therapy, whether it's medical therapy. So those people have to be kind of lockstep and be able to discuss these in an open forum and decide what's best for that patient, because there is not one size fits all, for certain.
And how does this integrate with the heart team approach? Because it's not just two people sitting in a room, you have an entire team.
Right, so I think that's actually where I really want to go with this. This is not the cardiologist and cardiac surgeon. This is the administrative people saying we're going to invest in a group of people here that are going to work together. And we just think on the physician side to start with, we need a group of imaging people, and that's CT, whether that's radiology or cardiology, that's your echocardiographers as well. You need a good cardiac MR group as well. So all of those have to be lockstep. Anesthesia has to be very supportive, because this is something that may be a little different from them because they're used to working in an OR setting. And with TAVR, that's maybe not as critical anymore because most of those are done under a MAC, but for mitral and tricuspid disease, where TE and general anesthesia are still used, they have to really be invested in this and we're used to working maybe outside the OR, because most of these procedures today are done in a cardiac cath lab, which may or may not be an area that they're working in if they haven't had a heart team. Beyond that really comes the larger team, which really makes it all happen, which is your nurses, your research coordinators if you're involved in clinical trials, your scheduling people, your clinic operations, all of that to move the patients from the day of referral or the patient calling in to actually procedure time. There's a lot of touches that have to occur there, and they have to really occur efficiently to build a really strong program.
Do you have patient navigators at Northwestern?
We absolutely do have patient navigators, because what you don't want to have, I think, and we learned this early on, is we don't want to have the nurses doing a lot of the scheduling of the patients for all the imaging tests, the appointments they have to have, the day of the procedure, where they're going, getting everyone lined up in all of these areas. It's not a good role. We want people working at the top of their license, right? Mm-hmm. And so I want nurses taking care of patients. I want physicians, doing the patient care work. But I don't want them being involved in a lot of the logistics that take up so much of their time and really is not efficient for the patient. Becomes frustrating for the patient, and certainly becomes frustrating for the patient care providers, and becomes a long time from the day you see that patient to the day you actually perform the procedure. And then the whole back end of this is the follow-up of these patients. So we rely a lot on our nurse practitioners, both on the intake side and on the care of the patients in a hospital, and on follow-up for 30-day and 1-year follow-up that's required by TVT, let alone all the research follow-up. And these patients are generally multi-system type patients, so they have medical problems that come up before, during, and after the procedure that, as a cardiologist and an interventional cardiologist, may not be something you really want to spend all your time on. You want to be involved with, but not necessarily involved with the day-to-day of that. And before you can turn them back maybe to the referring physician or primary care, your team has to be able to provide that interim type care for these patients.
And what about equipment? Early on, when TAVR became a thing, 12 years ago, there was a big push to have hybrid labs, so you could do open surgical procedures if you needed to bail out. But has that changed?
Well, yes and no. I think we started out with TAVRs being done more in the hybrid ORs, and we moved them up to what we call a hybrid cath lab, and much of that has been done by the fact that we can move patients through much more quickly. It actually improves some of the margins on the procedure, but I think we've not sacrificed safety. And so when we did that, when we built these cath labs, we built them to be functionally like an operating room. So if there is something that for some reason needed an emergency procedure done or emergency surgery, we can do most of that there, in there. The other piece, though, is we need really high-quality imaging in all of these, whether it be echo imaging or cath imaging. So I wouldn't just take your average cath lab and say, okay, now I have a TAVR program. Sure, you could do that, but I think if you really want to build a structural heart program, you should really invest in the high-quality imaging, the space that lab will require, able to accommodate anesthesia, able to accommodate potentially surgical options if that would become necessary. So space, imaging are very important, and this is not an area to cut back on.
With interventional echocardiographers, is this something that you have as a specialized person, or are you just pulling a sonographer in?
Great question. That is something that we learned also probably about 10 years ago. You need echocardiographers that are really devoted and dedicated to procedural therapies. And that's very different. We have a group of probably 18 echocardiographers, and really only 2 of them do interventional echo. And I want to speak a little bit more about that because we focus a lot on the procedural part of it, which I need them critically for. They're actually, as most people will tell you, they're one of the most important parts of the procedure, because if I can't see what I'm doing, I can't do it properly. Plus, they become part of that conversation of, do we do this, do we do that, particularly with mitral and tricuspid work. Not so much in the TAVR world where we rely on transthoracic echo, but I rely on them critically also to evaluate the patient's pre-procedure. So they do much of the TE, they do all of the TEs on our mitral and tricuspid patients, because there's different views, there's different measurements that we want to make that is not done on your routine TE. So I would develop that team early on. The other part is they're very much a part of our heart team. We have heart team meetings on a weekly basis. We have a separate aortic meeting, we have a separate mitral and a separate tricuspid, just because of the sheer volume. But they're on all of those calls. We review all of our imaging together, along with our cardiac surgeons and interventional cardiologists and advanced practice nurses and nurses. So they're helping us plan the procedure, get the proper images to plan it, decide who we should do, how we should do them, because we have multiple technologies. For example, we're involved in valve replacement trials, and valve annular repair, edge-to-edge repair trials. So we have a bit of a toolbox, and we're trying to say what's best for this patient, or are none of those best? Should we be thinking about surgery, or really maybe medical therapy is the best thing for that patient? Or we don't have anything right now, let's put them in a database, and maybe something comes along that we can offer them down the line. Or they're just, they're just not ready yet because their valve just isn't bad enough yet. Let's wait on that as well. So I think that's another critical part of building your structural program.
And at a hospital where they have the interventionalists and they have the surgeons, what have you seen at Northwestern in terms of volumes? Because everybody was afraid when the interventionalists are going to take all my volume. And talking to a few of the KOLs here at TVT 2022, there's quite a few that have said that their procedure volumes have actually gone up for both.
We've actually tracked this very well, right from the beginning days of TAVR and Partner 1 trial almost 15 years ago now. It's amazing. But we tracked our total aortic valve replacement volume, and that has continually grown right throughout. Now, it has shifted. It was 90%, 100% surgery. Now it's, maybe around 20% surgery for isolated aortic valve replacement. We're not talking about people with enlarged roots, bicuspids, that might require other work done. But overall, it's around 70 to 80%, I think, is where we're heading for that right now. We're seeing the same thing, for example, in tricuspid, which has been a really exciting area for us. It was only a small number of isolated tricuspid valves that were being replaced or repaired at Northwestern prior to starting our program about 6 years ago. And what we've seen is a steady uptick in the number of open surgeries that occurred, and a logarithmic uptick in the transcatheter procedures that have occurred. So this by no means cannibalizes one to the other. It's the old story that we're not just taking the pie and slicing it another way. We're really trying to enlarge the pie. And when we look at the disease prevalence of mitral disease, tricuspid disease, and aortic disease, and particularly the mitral tricuspid that are untreated, it's enormous. So I really think people need to take the big picture approach to this. And even if in the short term there's maybe some resegmentation of population, I will almost guarantee you that long term that will not be the situation.
Do you think that it was just that the surgeons were seeing patients that actually qualified for surgery and everybody else is just kind of thrown to medical therapy in the past, and that you didn't really know what that pool was?
Right, I think so, and I think surgery has had challenging outcomes because, particularly in the tricuspids, these are generally patients with multiple comorbidities, fairly sick. You look at the surgical literature, there's a small number being done, and the outcomes were not super. And so they often, left them untreated. And then I think there was an awareness population, and that's still ongoing. That will have many years ahead of us. But general cardiology or specialists, even primary care, people, well, they have tricuspid edema, I'll give them diuretic, whatever. But as we look at these natural history curves, we realize, hey, there's a 20-30% one-year mortality, there's a 40-50% 2 or 3 year mortality. So they're not doing so well on medical therapy, and undertreating them may not be the best thing. So we re-educate the community. I'm seeing referrals now from people we never would have seen before, and even in the last year or two, our heart failure group has completely flipped on this. And I use them a lot actually because I bring all patients in for prehabilitation prior to a procedure for tricuspid, and afterwards they're often following them along. So they're seeing, hey, these patients actually doing well, getting better. And their mentality has changed a bit on that as well. But we need to educate the broader community out there to understand that mitral disease, you don't have to wait for symptoms to refer them in. And so as we get that along, that's what I think also grows these programs.
And lastly, because you are from Northwestern, you guys have something like 9 hospitals now in the greater Chicago area. But while you have a concentration on these really intense cases downtown in Chicago, your satellite campuses are now starting to do TAVR procedures, and they've been doing this for a few years now. Are you be able to pick up additional volume through that?
So we now have TAVR in 4 of our hospitals out of the 11. We actually helped them start a couple of these programs because we recognize that TAVR has become a little more of a commodity item, particularly in the Chicagoland area. People don't want to necessarily travel 20, 30 miles downtown. It's a little scary for people to come out of the burbs and to do that. So they want to get that type of care locally, and so we've supported those programs. We still see some of the more complex TAVR work from them. Some mitral valve and valve work or aortic valve and valve, most of those will still refer on to us. So we still see that, and that our TAVR program still continues to grow a bit. But what has really happened is because of the awareness, and they built heart teams out there as well, awareness of valvular heart disease, that things that they're not doing, tricuspid, they send it to us regularly. The complex mitrals, we have one of our hospitals that actually does edge-to-edge repair for mitral, so they'll take those on, but if they're more complex edge-to-edge repair, they'll send them on to us, or if they think there's some that can't be repaired, and there are those that are not going to be addressable by an edge-to-edge, they know that we have other options, including transcatheter, transeptal mitral valve replacement. So I think you should, once again, we think of that as a partnership. We could have said, well, we want all the procedures, transcatheter, being brought to one hospital. There are hospital networks that do it that way. We've taken a different approach, and quite frankly, I think it's worked out well for us and for the patients.
I appreciate your time.
All right, thank you. Pleasure.